My name is Alan Pitt. I'm an attending physician at the Barrow Institute, and I'd like to talk about sustainable business models for telehealth. A real question is, why has telehealth not become more ubiquitous? Why is it more of a curiosity? I personally feel that many of us in telehealth have focused more on the technology rather than the problem that we're trying to solve, which is really access. If one looks at how to enable access via telehealth, there are multiple components that need to be considered, including stakeholders, business models, barriers, and future opportunities. The stakeholders go beyond the patient and the physician to hospitals, rural access points, employers, and payers. All of these need to be aligned if telehealth is to be successful. They all need to be able to see a return on their investment in time and dollars. I really break it out to three models: fee-for-service, bundled payment, and then finally efficiencies within a hospital. The fee-for-service model is the easiest to understand. This is the typical telestroke program or second opinion. Bundled payments are becoming more and more part of the marketplace. In this case, disease management. How do I manage the patient, the very expensive patient with CHF or asthma? This is typically a phone center. This would be better off in telehealth. And then finally, efficiencies. How do I share information between nurses and physicians, physicians and physicians within a hospital as well as outside of a hospital? Being able to share information in time means a patient is going to receive more timely care, less expensive care, and this can also be enabled within telehealth. So if we were to look at a telehealth program, what are some of the considerations? Well, you need to figure out what the return on investment is. This requires understanding the net revenue from the payer mix, variable host costs, including FTE and hub costs, as well as what are the costs to the spoke. Many times people don't consider that you can give a spoke hospital technology, but then they're required to maintain that. They need technical expertise. Physician costs can also play a large role in determining the ultimate ROI for telehealth, and this can in part depend on the ease in which a physician can participate. Finally, there are fixed costs over time to running a telehealth program. Let's take this one step back. So if we were to take an urgent care, they would certainly benefit from subspecialists on call to back them up if they had a patient in need. The specialist typically stops that dialogue with, how much are you going to pay me for 24/7 coverage? Hospitals look at the same thing. They basically want to know, how much am I going to get paid? But here the models can become a little more sophisticated. How many and what type of patients are you going to send me if I give you backup coverage? The urgent care center also wants to know, how long will it take if I send you a patient so that I can brand this with my community? Ultimately, what we really want to understand is, did we provide a better overall outcome for that patient moving forward by having telehealth services available? All individuals involved need to be able to see either immediate or downstream revenue with conversion of that patient to tertiary services if this is to become sustainable. Second opinion is becoming more and more prevalent. Here's an example from Johns Hopkins. You can find this at many centers of excellence. Consumers are looking for services that they can't get locally. They're willing to pay with their own dollars for a second opinion. This is consumer-driven healthcare. This is currently largely a paper-based system, but really should be in the purview of telehealth. Bundle payments for chronic care management are also quite pervasive. Again, however, these are typically a call center. They don't involve the patient's reported outcomes in an automated way. They don't involve video for relationship building between the care provider and the patient. Internal opportunities include improving efficiencies throughout the hospital, and there are many papers documenting that information moved between nurses and doctors can improve care. This can be significantly accelerated via the use of telehealth technologies for internal improvements and reduction in cost. What are some of the barriers that we currently face? Traditionally, technology in telehealth has been large and clunky. They've been access points. We need to move to something that is much more ubiquitous. In this way, any device can participate in telehealth rather than simply access points that are scattered throughout a state. Here's the Michigan's stroke network. Good, but not great, because you basically have to find one of these access points to participate in telestroke. It does not get at a more internet ubiquitous environment for participation. Physicians object to, I must be chained to my computer if I want to participate in telehealth. They want to be able to be mobile to participate. Workflow is also incredibly important. Telehealth has to be looked on as an activity of equal revenue compared to your typical clinical practice. In terms of reimbursement, we have really been stuck in the idea that rural care deserves particular codes because this is considered underserved. But in essence, we are in some ways paying ourselves. Distance and times both impact patient compliance. Patients who are not compliant tend to be more expensive over time. By improving access, patient compliance goes up, and we ultimately save dollars. Licensure seems quite artificial in today's world of internet, but still a physician in the state of Arizona can't see a patient in New Mexico, even though their competence would not seem to change as they cross state borders. We need newer, more modern laws in terms of our abilities to take care of patients across the country rather than just across the state. I'm a very big believer that we cannot continue to introduce technology into healthcare without having some sort of transparent outcomes. As Bill Gates says, innovation often makes healthcare more expensive rather than less expensive. We can't look at the telehealth tools as simply something that's good for patients. Rather, it has to be something that's good for patients and that it saves money. So what are some use cases that one might consider? So for instance, schools could act as kiosks. We currently don't leverage this. A school could be a place for education, a good meal, as well as care for the student with chronic illness. Realize, of course, when a student with chronic illness has to go to the doctor, they're missing a half day for a 10-minute visit, both they and their parent. Employers don't really want their employees wandering off to go see the doctor, again, hours away from work for a 10-minute visit. Appropriate triage between rural access points and tertiary centers needs to become more transparent. Prisons spend inordinate amounts of money literally transporting patients between facilities in order to obtain access to specialty services. And finally, as I mentioned, there's a huge opportunity for internal exchange of information between providers, not simply a phone call, but rather visualizing the patient, visualizing the images between the referral network inside a hospital, as well as between a hospital and a rural center. Ideally, what you want to be able to do is take the virtual experience and emulate what we do in bricks and mortar. So today in a brick and mortar experience, the patient has a waiting room, a receptionist, a nursing intake. There's a chart on the door for the physician to review, and then the physician comes and meets the patient. Today in telehealth, it's typically provider-patient brought together over information without this workflow. This is essential for a stable model. So in this case, this is one example where the patient fills out information, pays for services rendered, they go into the virtual waiting room, the provider can see the list of patients necessary to be seen, they review the information in a way that's comfortable to them, they activate the video conference when they're ready, when they've looked at the chart, they have the video conference, they can order pharma online, and then the patient receives a disposition with information about next steps in terms of their illness. Again, emulating the brick and mortar experience in the cloud, making this a revenue positive experience for both the patient and the provider. Ultimately, you want any device, any network to participate in a telehealth experience. And this can include information not only around the patient, but around the community of patients that a provider may be taking care of, or a particular disease class of patients, so that we can see relevant outcomes. Many programs are now looking for specialty telehealth programs. I personally think that this may be a mistake. I think what you really want to try to look to do is build out a scaffold that can support workflow and interchangeable content along with a community of providers. So take, for example, the idea of building out telepsychiatry. I think the idea of building out a telepsychiatry program is good, but could be made better by keeping in mind that moving forward, you not only want to use that infrastructure for telepsychiatry, but also for diabetes, congestive failure, asthma, back pain, other specialty services that can be delivered through the same infrastructure simply by minor modifications in the workflow, as well as content provided in the cloud. The same community of providers can offer different services on this infrastructure. We all know that healthcare walkabout, basically a patient has to travel the world to look for health amongst various providers. This really makes no sense. It's very wasteful in terms of the patient time, and overall, because of the lack of communication between different providers, ends up delivering suboptimal care. Ultimately, in my world, the medical home is a place where you stay when you're sick, where people come to visit you and offer advice in terms of making you well. This may include the patient with their nurse promotora or primary care doctor who works as a guide through this process, but the patient should be able to remain fixed, and a community of providers comes to assist the patient in going from sick to well. In the world of telehealth, we can begin to leverage expertise where we go from one-to-one to one-to-many. If we look at telehealth as ubiquitous, we can bring in expertise on the fly so that the primary physician can draw upon those on an as-needed basis to help them in their care of their patient. As we look at this triangle or pyramid of care, we have further opportunities where we can aggregate patient data in the cloud and begin to see outcomes. There's a large focus now on ACOs and provider utilization. Many providers are banding together to form an ACO, but recognize that ultimately an ACO is about the patient and value, not about providers. So what can we do in the telehealth community to really move this forward? I think we need to move our focus off of infrastructure, off of technology to problem solving and access. We need to identify and collaborate on use cases. We each have our own pain points that occasionally the community hospital has and the tertiary hospital can solve. These need to be identified. There needs to be active lobbying for revision of codes, licensure, and I think an Office of Telehealth that gets up every day and is focused on how can I improve access needs to be established. Finally, employers need to be actively brought into the space. They are clearly stakeholders in this and have a voice in this, this technology. I want to thank you very much for your time.